This meeting is being recorded.
Good afternoon or good morning, wherever you are. I am Sandra Whitehead. I am the current president of the Society of Practitioners of Health Impact Assessment, SOPHIA, and it's my honor to welcome you this afternoon to our Health in All Policies practice webinar series. And today we are welcoming Dr. Judy Goforth Parker, and Emily will introduce her in a moment. But I wanted to welcome everyone and give you some SOPHIA updates. As you know, these webinars that we have been having since January have been a mix of social and practice webinars. We had our SOPHIA town hall on our strategic plan last month, and we're having a members only social hour next month for our webinar. And we are in the process of adopting our new strategic plan. And so I would invite you to go to hiasociety.org and check it out. It's on the main page right now. And if you're not a current member of SOPHIA, please connect with us and join. We are still running a special discounted membership through the end of June, and it's for $22 in honor of 2022. And I see that Emily is having some connectivity issues. So why don't we do this? I will go ahead and introduce Dr. Goforth Parker. Judy is a member of our Health in All Policies work group. And we have been updating the website and working on updating some of the guidance and the policies on the web page. And it's been my honor to chair that the last couple of years, and we've had members of that working group present to our membership the last few months. And Judy's webinar on the health impact checklist, using it in for troubled governments, is our current webinar. Judy, take it away.
Okay, thank you, and I appreciate you for inviting me today. Sandra, I did want to ask if, I don't know if it would be you or Emily, did you all get my poll questions, and can we use one of those right now?
We do have those, and try to upload this.
Yeah, I don't see on my thing a way to bring it up. I'm working on it.
Okay.
Judy, we might need to just kind of put those in the chat and see what answers we get. I apologize. I'm not super familiar with Zoom.
Well, I really wanted to, after you've introduced me, I wanted to know a little bit about the group. And so I was just going to ask if anybody has ever been to Oklahoma, or have you done work in Oklahoma or lived in Oklahoma? And it doesn't count if you were just here when you flew in and came to Will Rogers Airport, so, or the Tulsa International Airport. But that was one of those questions I had. Anybody, just say, put your answer in the poll. And if not, I'm going to introduce you to Oklahoma. The other one is, I wondered if anybody has worked with a tribal nation before. You know, there are like 590 plus tribes in, oh, here I see somebody who's been to Oklahoma, graduated from Southwestern Christian University. Great. How about tribes? Have any of you worked with tribes before? Someone from Texas. I had someone ask me yesterday in a group that I was in, what is your accent? And I said, well, a little bit Southern, a little bit Oklahoma, and a whole lot of Texas, I'm afraid. So if you wonder why I sound the way I do, someone's worked with the Navajo, the Zuni. That's great. I just wanted to see, get a little bit of an idea on your introduction to tribes. I thought it might be important to share with you a little bit about the Chickasaw Nation. We are in like South Central Oklahoma. We have about 12 and a half counties. 2 years ago, we would have said we were basically a non-reservation state, but because of a Supreme Court decision, it was decided that our reservations were not obliterated like in the 1900s, 1800s. And so we are now considered a state that has reservations. And so the Chickasaw Nation land territory is now reservation. We have about 75,000 members of the Chickasaw Nation, and a lot of our tribal members work for us. The Chickasaw Nation actually has 14,000 employees. So we're pretty much I think, an important part of the economy and the culture of Oklahoma. And I just wanted to share that with you a little bit. When statehood occurred in 1907, they were trying to say that tribes are sort of no more. And tribes really didn't take that. They didn't buy that very well. When our Constitution was ratified again in 1983, we had 100 people working for the Chickasaw Nation. And now, of course, that's grown to more than 14,000. So we're a pretty big impact on the economy and the culture of our nation. I was going to share with you, I know that you all know what health and all policy is. I had one of my poll questions that I was going to ask you was, how many years have you been practitioners of health impact assessment or health and all policies? I'm kind of, as I would say, a little bit new on the scene, newer, because I know that Sandra's worked with it a lot of years, and some of you probably have as well. But our tribe really did not know very much. I mean, I know there are a lot of people within the nation who I think probably were aware of health and all policies, but when I brought it up to the groups that I was working with, it was a pretty new concept. But I felt that it was something that would be very important because we have a lot of policies. I was introduced to the topic when I was working on a postdoc at Meharry Medical College, and my main professor. So I see someone is saying 9 years, 10 years, 15 years. And that's kind of what I thought, is that you all have a lot of expertise. And so I wanted to share with you what you were able to share with me, and then I was able to share with my tribe, which has been, I think, very important for us. But back to Meharry, my professor had me start looking at health and all policies and health impact assessment. And through, I guess, a variety of just email searches and searching the web, I somehow one day ran into the name of Dr. Sandra Whitehead, and Sandra and I set up a call. Sandra, if you remember, it was very much during COVID because we were both sitting in our homes working 100% from home, not going anywhere without mask. And I started talking. Hello?
It was early in COVID.
Very early, very early. It was like probably March of 2020, I think, when we had one of our first discussions, March or April. And so it's now been 2 years, Sandra. And so Sandra introduced me to a lot of the concept, and then also gave me ideas on, what could I do to reach out to my tribe. And that was the main thing I was trying to do at that time. So these were the concepts that I introduced. And what I did, the tribes are we're very much, we have oral histories. As you know, that we didn't have written languages. And so our traditions and our orals and our language, everything was shared by the storytelling and oral languages. So I started thinking about storytelling and how do I share this, because what Sandra encouraged me to do was, find an area where you think that there's going to be some interest, a lot of buy-in. Maybe it's a small group you could get into, or maybe you could invite some people in, but there were just a lot of different ideas that we had. And I was looking for, anything that had policy with it. So we had a group that had a subcommittee that was a policy subcommittee. And so that's where I jumped in. But what I shared with them was, with health and all policies, I like the thought of what did the policy of removing sidewalks from our communities do to us? It was like we don't need sidewalks anymore. People are driving their cars, they're getting to work in that way. And so city planners basically took sidewalks out of the planning method. And so I don't think they really ever thought, do you think, well, what will this do to the health of people? What will it do to the way we communicate? And so I thought, wow, that's probably going to be a good way to share my story and share with the committee that I was working with, is what is health in all policy and how could it be a positive thing for us? And so that's where I started. What's interesting about all of that is that you found out, and this is for the number crunchers in the group, you found out that not only did it have an impact on health to take sidewalks out and to put them back in, people tend to walk more. People, there was a lot of safety issue related to sidewalks, but also for the number crunchers in the group, it had a huge economic impact too, because if you put $2,000 into a sidewalk, then you have a 15 times return on your investment for that. So those were some of the things that I used as, what would you say, kind of a hook to get people interested. And it really wasn't very hard, I think, because if you think about it, and for me to go back for just a moment, tribal governments are just that. We are sovereign nations. And so the Chickasaw Nation is a nation within the nation of the United States. I actually have a dual citizenship. I'm a member of the Chickasaw Nation, and I'm also a member of the United States of America. So those are my, two allegiances. I was an elected tribal official, and when we would do our swearing in for the oath of office, you would swear allegiance to, the Constitution of the Chickasaw Nation first, into the United States of America. So, tribes are governments, and we work on a government to government relationship with the federal government. So if you think about that, the United States certainly has a lot of policies. States have a lot of policies. Governments or, organizations within states have a lot of policies. Well, tribes do too. I mean, we're run by policies, and I think it's probably not unusual. I think everybody really is. I wanted to share this slide with you that I found from the Sycamore Institute that is also there in Tennessee. And I know that this is one, again, that you all understand it. You know that the health care that we get in the clinical care is not the greatest part of our lives where the health is impacted. I mean, like 20% comes from your clinical care, 80% from outside of that. But most time when people think about health, I think they think about the clinical care that we get. And so I wanted to share, I thought this slide really told the story very well. And so I thank you all as practitioners of health in all policies or health impact assessment, that you understand that. And I think it's important to, when you're sharing that with people who don't think in that way, you're trying to get them to change their way of thinking. This picture, gave me a lot to go on. And the part on the right where it talks about health in all policies, I mean, those are all things that are about what we're about, transportation, communication, education, the trust responsibility between the United States and federal and tribes really, promises that healthcare. So the healthcare we're really very much interested in. And we put a lot of resources into that, and we put a lot of importance in the health and education of our people. But thinking of the health, tend to think that's where health is going to come from. So everything we get about our health, well, we know that's not right. And then another thing I was just going to share before we move forward is that I wanted to look at it also from a cultural point of view. And that's really important if you can help a tribe to understand the concept, but also understand culturally. So I think one of the biggest ahas that I had about health and all policy and how policies impacted our health in the Chickasaw Nation is I thought about the removal policies. If you go back to 1803 with the Louisiana Purchase, which encouraged settlers to go west, people were moving west. Tribes were all over the United States, actually. We were in the East. And so the Federal Indian Removal Act of 1830 evicted a lot of people, a lot of tribal people from the Mississippi area. And our last residence before moving to Oklahoma was actually in the Tupelo, Mississippi area. We were in Tennessee, but they removed all tribes from Tennessee. So you can go to Tennessee now, there's really not a tribal presence there unless it's individual people, but there's not a tribe like what we have here in Oklahoma or in New Mexico or Arizona and states that have a lot of tribes in them. But we were removed from the Tupelo area. And I think about how that impacted us. It impacted the way we hunt our food, the way we gather our food, the way we communicate. It impacted our relationship even with the land, because as you would think of that, tribes, we had a very strong relationship with the land, and it wasn't like any one person owned a little section. You had large regions that you protected and took care of. So when we were moved to Oklahoma, I think about the policies related to food and the way that food was changed, the way we hunted, and food began being distributed to us. And that would actually be called the federal government distribution era. And really is probably where we started having more problems with obesity eventually, and diabetes eventually, and cardiovascular disease. And I think that what I shared with the committees and the different people, Sandra, I've had an opportunity to share this with a lot of people within the nation. I think that this part was really easy to grasp because you looked at what the federal government policy and the removal policies did to us, and then how we're now trying to counterbalance or counteract some of those negative impacts. And this one is just like kind of a picture, picture's worth 1,000 words, I guess they say. But this one is like one of the things that we're doing with our own policies. And as we're trying to preserve our tribal sovereignty and then food sovereignty. And food sovereignty is when you start making the decisions of, this is what we're going to eat. This is what is going to be better for our nutrition and better for our health. And so we're having to do a lot of teaching. And then just the fact that food sovereignty is actually, learning to say, like, I'm going to grow part of my food. I'm going to have chickens and we're going to have our own eggs. I mean, those are things, growing our own gardens. We have a lot of gardening projects where even around our clinics, we'll have small gardens that children will come in and, plant strawberry gardens or vegetables. And so it's a good way to help us to improve our health and take back over some of the things that we lost. But these are just policy impacts and how you can help people understand, what is health and all policies, and why do I need to look at that a little differently. I think it's very common, again, as I said, to think of what I do at the clinic. That's really about health, but really what happens outside of the healthcare system is a big part of what happens with health. And I was very fortunate that we were able to, I was able to find a group that was looking at the mental wellness of the Chickasaw Nation. Back to our government for just a moment. Our current governor was elected as lieutenant governor in 1975. In 1987, he was elected as governor, and he has continued as governor and, to this very day. So we have a very stable government. He has a cabinet of, I believe it's 10 cabinet members right now, and each of those cabinet members is over a department. And they are things like the Department of Health, Department of Communication, Commerce, Family Services, Human Resources. So there are 10 departments. And the one thing that he said is that he believed that mental health was impacted in everywhere that we work, in every area. And so we started a mental wellness initiative actually in 2019. And it was really fortunate for us that it happened, right before COVID, because the committee was able to establish itself. And Sandra, are you saying I have 5 minutes? Okay, so we're going to move on, maybe a little faster than I had thought. But the committee, that's where I linked in. And I'll show you that on this slide. It's one of the slides. And if you're close enough to your screen, you can see that we have 4 pillars that things are based on, and it's social wellness, psychological wellness, biological, and spiritual. The social really has to do with our culture. And so as Sandra had introduced me to Health in All Policies, I began looking for, what is something that would be a little bit easier to do, because a health impact assessment is, there's a lot of time commitment for that. And so Sandra then at that point in time introduced me to Tatiana Lynn with the Kansas Health Institute, who introduced me to the health impact checklist. And I would say to you, if you go to this slide, if you Google the Kansas Health Institute or just the health impact checklist, this is where you're going to land. And what I found in going to that, the Kansas Health Institute and the health impact checklist, is that it was something that was very tangible. It was something that I could share with the tribe. It's something that we could do. It would bring in a lot of sectors of people working on some of the same issues, the same problems, where it really fit in very well with what we were doing with mental wellness and with our governor's vision that mental wellness and mental health is impacted in every area of our tribe. And so how can we make sure that we're helping people? And so it worked really well because I had a vehicle to use. This is a slide that the Kansas Health Institute put together. And what I really like about it is that it just really points you in the right direction, a process for beginning to look at the concepts, of health impact assessment and how that can then be strategized using this checklist. And one of the things that I really didn't anticipate when we first started this is that the Kansas Health Institute had done the checklist, and we started looking at it and realizing that, this is going to work for us. And then we realized that it really looked at a lot of concepts that were important to us, but there were parts of our culture that we thought that were really not addressed. And I want to share that part with you. Sandra, let me ask you right now how I'm doing on time, and then I can move forward to the part I want to share. So I'm gonna stop for just a minute.
Why don't you go ahead and continue for maybe another 10 minutes? I wanted to make sure we have enough time for questions.
Okay, all righty. Well,
Thanks.
Thank you, Sandra. I appreciate that. You'll have to remind me about the 10 minutes because I can probably talk quite a long time.
Be glad.
I'm pretty passionate about this. It's been very exciting to me. The criterion that we use for using the tool, we wanted something that was evidence-based, and we really wanted something that would pull in a cross sector of the Chickasaw Nation, and also let us I didn't have anyone that would call themselves a practitioner of health impact assessment. That, like SOPHIA, which I've been so fortunate to be a part of that for the last 2 years. But we needed to have a tool that people would feel that they could use. And I think that's what we've come upon. On the checklist, this is like a very easy way to look at it to see, is this something that we need? Is it something that our community would be interested in? Is it something that decision makers, would like to use something like this to help them see that there are parts of policy that have an impact on health that they had not considered? And I think, to me, that's probably one of the most important things. I wanted decision makers to learn about the health impact assessment, and I wanted them to realize that we could use a tool to help us look at our policies. Because as our governor has a vision and has had for a long time, is that the health of our nation is very important. So that was what really worked for me and what helped me a lot. I think I'm going to move to this next one. I want you to see this one. This is the actual document that the Kansas Health Institute for the health impact checklist. And I thank again Tatiana Lynn for the work that we've done with her. And I'll just remind you again, we didn't begin in the thinking we're going to change this. We're not, we really started it off and actually did a pilot with the tool without making any changes to it at all. This slide, you'll see various conditions that could be affected by regulations or policies. And so I think these are probably concepts that you are very familiar with looking at. And when you're thinking about health impact assessment or health in all policies. And so this is where we started. And this is the second page of that tool that I wanted to share with you. We were fortunate that Tatiana came in and did some presentations for our group. She's actually met with us several times as we started trying to implement the health impact checklist, or as you would call it shortly, HIC. She came in and worked with us, and we were able to do a pilot. And then Tatiana came in and went through some of that with us. And I think it's at that point when we realized we went back to the mental wellness initiative. We went back to those 4 pillars that I shared with you at the beginning. And we realized that we're not seeing that side of that in the checklist. And so we started looking at it for a way to adapt that and make some changes. And so this is really what we've come up with so far. We have been able to make some changes, look at the culture of the Chickasaw Nation, and see how there are what areas like, language preservation, the food sovereignty, as I'd mentioned, some of those areas that we felt, and language preservation is really important to tribes. Because of our early European contact, we lost a lot of our language, and we have very few, speakers who are fluently speaking Chickasaw at this time. So those are parts of policies that almost every area and department of the Chickasaw Nation addresses that. And so that would be an important part of the adaptation as we were looking at the adaptation. And then I wanted to share with you, and at that point in time, Sandra, I think I would be ready for some questions, is that this is a part of the health impact checklist. And on the very early outcomes of some of the piloting that we've done, because we did a pilot first with the original checklist, and then we added to it, and we've started piloting that. And some of the feedback that we've gotten is that it's easy to use. It encourages research to inform us of the impacts of health on that the SOP, or standard operating procedure, and that's some of the terminology we use, might have on health. It helped us identify partners that needed to be at the table to contribute to the plan or to the standard operating procedure or the policy. It kind of depends on, we're giving people the opportunity to call it a project or a standard operating procedure or a policy. It's helped guide our team to consider the populations that are being impacted by the policy or the standard operating procedure. These were some comments that people made. They said that it helped guide the team to identify positive and potential negative impacts on health. And the other thing that I think that we've done that's a little bit different is we actually took policies that were in existence and maybe we were doing some changes to those. And so that would be an opportunity to use the checklist and kind of give the policy another look. The one that we first started out with had to do with working remotely. And so, of course, that fit really well during the pandemic. It was the perfect place to start because for a period of time, probably, maybe 70% of our 14,000 employees were working remotely. Mostly the people who were directly in patient care were the ones that, stayed at their traditional workstations. But a lot of people work from home. And so we very quickly needed to adapt that policy. And we were able to use the health impact checklist at that time. So I think that feels like it went pretty fast, Sandra, but I'm going to stop now. And if you have questions, or even if you have ideas of what you think we should do next or what you would have done differently, if you put those in the chat, I'm open to questions. Thank you.
Thank you, Judy. I really appreciated the level of detail that you were able to talk about how you guys, piloted the original checklist. One of the things I'm going to take the moderator's privilege of asking the first question. One of the things I'd be interested in learning more about is which of your departments were able to use it, and just to hear a couple more examples of things that you guys changed that made it more useful or for your tribal situation.
The first department that used this was related to human resources. And that was the department that was making the changes related to the working remotely. And so that's where we started first. And now the Department of Family Services, and the Department of Family Services, which is where we have all of our behavioral health. I mean, it's kind of separated out from health. And so the Department of Health has psychiatrists and psychologists, but in the family services, we have a great team of marriage and family therapists, and a lot of our therapy work where our patients come in for visits for mental wellness. And so that's the second team that is looking at the checklist. And then I'm going to go back to actually have it right here in front of me. With the way I had it on my screen, I couldn't look at it without it looks like you're looking up into the stars, and I couldn't see my screen, so I didn't see all of the things that I wanted to tell you about. Oh, I know we put on about traditional beliefs and practices. How would there be a possibility that a policy would have an impact on that? Would it be positive? Would it be negative? Those were the pieces related to our culture. We added in a section about telehealth because, as you know, health has greatly been impacted with COVID, and telemedicine being added in. And so those were some areas. Oops, can't hear you now.
I was on mute, apologies. I don't see other questions in the chat yet, but maybe it'd be helpful if you unshare and people can turn on their cameras.
Sure.
And ask things. Thank you to those who were able to turn their cameras on. It's nice to see your smiling faces.
Can I ask a question, or are we supposed to put it in the chat?
No, you can unmute yourself.
Great, thank you. Hi, my name is Mary Merrow, and I am joining you from Minneapolis, and I really appreciate all that you've shared today. And one of the questions I have, I've worked a little bit with the High C, and one of the challenges I found is I'm not an expert at all, but in trying to understand what the potential health impacts are of something, like you talked about the remote work situation or whatever. Some of the process that I've been involved in has been looking for research or evidence-based, information to help inform how, what some of the health impacts might be. And I'm curious if you used that approach. I can't remember if you talked about it, and how you, like, I feel like sometimes there's gaps in what research is out there about the different issues you might be interested in using the high C for, and if you, how you figured that out, or if you did.
Well, I mentioned Tatiana being a great resource and a great help to us at that time as we were learning how to use the checklist. And I agree that, like in like the remote work, I think what we did is that we just looked for, and I don't think there's a magic answer to that. It's like the research is sometimes it was like with us, the people that in that area realized that a problem with working remotely would be the isolation. And that was some of the things that they were being faced with, was people that, didn't work well in isolation, or working at home was not something that was really conducive for them to be able to stay on task. They got too many distractions. And so as far as research, I think in that situation, it was a lot related to what we had already experienced, because in the Department of Health, maybe 10 years ago, we started letting people work remotely that were our coders. So we used part of our experience as the research. And then the other thing that I had the tendency to do is I was like getting too deep in the weeds. I remember all these Zoom meetings where I would actually see people slouched down in their beds. And so I got all about the ergonomics. I'm a nurse practitioner, so I wanted to do the health part. I wanted to have something in there about, ergonomics, and we need to get people, a lap table or whatever. And so we had to, I think that was another thing I was learning about it, is that you have to kind of, you've realized that there are a lot of areas that there can be an impact of health, but what are you going to focus on? What's going to be the priority? And I think Tatiana said, ergonomics may not be the priority right now. It may be more the part about the social isolation. And then later on, if that ends up being that person's problem, then we would work with that. And I'm not sure that answered your question exactly, Mary. I'm trying, but I know that, I remember too, and you probably, since you've worked with the checklist, that they have a toolkit that has a lot of resources, and you'll see how they did a lot of research. That have many articles. And that was a little overwhelming too, sometimes thinking, well, how much do we need? How much research do we need? But I think everybody answers that question kind of on their own.
Thank you.
Thanks. Oh, go ahead, Valerie, and then we'll go to the question we have in the chat once you're.
Thanks, Sandra. Judy, I just wanted to ask, you were talking about reclaiming language and also the food sovereignty aspect, and I wondered if you had traditional programs that incorporate hunting and gathering and the skills, the life skills that Native people had, like basket weaving and some of the other traditional forms that are associated with food systems.
We do. We have the basket weaving, the hunting. I know that we have like there's a pretty robust program related to that too. We have land where people, you get a license and tribal members can go and hunt. And we have a bow season that, people pass on those traditions. It's not as much a formalized program as the basket weaving and some of those arts, and cooking, where we're trying to, we have a special cookbook that we created that uses some of the foods that come through what we would have traditionally called the commodity program. And it's, it's the food distribution program now. But anyway, we have a cookbook that we created so that people could take those foods and be able to learn how to cook them in healthy ways. So there are a lot of programs. We actually have a program on the language preservation right now that it's very new. It has like 7 people in it, but it's like one of the immersion programs where they spend 40 to 60 hours a week and they'll only speak Chickasaw. And that was pretty major, and it's a huge commitment because that's basically your job, is that your job is you're going to become a fluent speaker. So I did not do that. I get in classes and learn words from here and there. Thank you for that question.
Thanks, Judy and Valerie. There's a question in the chat. Audrey'd like to know what advice you have for bringing the Hi-C tool to others who are new to making decisions with health as part of the considerations.
This is a Judy version of it, because I really think if you find something that speaks to somebody's emotions, like my example, because tribes are so aware of what the removal process did. You know, if it was you're losing all of your land, which my family eventually did. We had 140 acres that were allotted to us. But if you come at it and give examples from where somebody can feel sort of emotionally. The sidewalk thing was the one that did it for me, because I remember playing on sidewalks when I was a kid and then living in communities without them. But if you can get an example that they understand, because see, you all may not have related to the sidewalk thing. You think, why are you showing us this sidewalk? Or, you know, what does, you know, I guess the canned meat that had 1 inch of fat on, that was the one that got me, was the foods that came through the food distribution program. And I realized it was policy, you know, and so I had the big aha moment. So I think, to me, that's, if you just give examples where they understand, because it's what hits them emotionally, because we're all where we are, I think, because of this is what, you know, this is what I want to do, or I'm emotional about this. It's how I want to impact people. Does that make sense?
Lots of nodding heads. So
Okay.
we also have a question from Kojo. They say, thank you for sharing your work. And they're wondering that in addition to identifying the pieces of the 4 pillars that could be accounted for in your adapted Hi-C tool, what was the process like adapting it to your community? Namely, who were the individuals, groups, or communities who you collaborated with to determine what factors were important to add to your adapted tool?
Well, I had a great mentor named Sandra who told me, find somebody who, you know, like when I found the policy subcommittee, you know immediately that you have people who don't cross their eyes at you whenever you say, I'm interested in policy. But I knew that they were drawn to policy for some reason or another. And I think that to me, that was what, you know, as Sandra said, find somebody within the organization that understands and they're interested. And then you either grow it that way and people get interested, or you try to reach out to a bunch. And I think I'm trying to grow it from, I found people who support and like what I'm doing. I remember thinking, oh my goodness, you all like this. And then I would be so excited. And then, you know, that they wanted to pilot it, and they, you know, they just started piloting among themselves, and you could see that enthusiasm. And that's, you know, so I thought, well, I found my home. And I think I told Sandra, I found the right people. I found someone that would listen. So
tell me a little bit about the pillars, and just to clarify the question a little bit, the way the pillars accounted for the changes that you made in the tool. How did you incorporate those into your use of the tool?
look at the one that really looked at social, and that really was originally called cultural pillar. And then we changed it to social. And then there are a lot of concepts or constructs under that that we identified as that social part, and culture was a part of it. And so that's the other thing that we did, is we invited a Chickasaw elder who is revered and acknowledged as a Chickasaw elder, who's more traditional, and we invited her to our meetings. And so as we were adding in those pieces that had to do with the culture of the Chickasaw Nation, whether that had to do with our language preservation, or if it had to do with traditions, I know the traditions were in there. And then about the part about the food sovereignty, food preservation, tribal sovereignty. Tribal sovereignty was another part that we kind of figured out. How do we put that in there, or do we not? But having an elder within a tribe was real important. So we brought that person in. And then the parts related to, of course, the biological, which is physical health, is real obvious. The mental health, we were in that, that's really the department of the Chickasaw Nation that really has worked with me a lot on this. And so we made sure that we had sections related to that. But it was just really fortunate that all of this was being built at the same time. Sorry for the hand movement, but anyway, it was being woven together at the same time.
And the people on the policy council, those are the leaders of the different departments or divisions that the nation has?
They were, yes, what we call Chickasaw and Note Philly, which means thinking Chickasaw. And that, the reason we changed, that was the whole mental wellness initiative, was changed its name to Thinking Chickasaw. And then we have the Chickasaw word for that. And the mission statement of the Chickasaw Nation is to enhance the overall quality of life of the Chickasaw people. And so to me, that's very holistic, the overall quality of life of the Chickasaw people. And so I think that, to me, the pillars are very holistic. And for a time that we had them in these columns, like they were straight columns, but the communications department took all of that wording and those definitions of the 4 pillars, and they put them in a Venn diagram where they were all connected with well-being in the center, which to me really goes back to that enhancing the overall quality of life of the Chickasaw people. And that's how the whole cultural piece to me is woven into it. It's kind of like having on a lens. It's, you know, we just think that way. I mean, that's why I think they call it Thinking Chickasaw, because it's the way we think, the way we look at things.
So tell me, who is in your core group of people who you brought together? You talked about your champion. Who are the other members of your policy council?
Well, of the committee that has maintained working together and working with the checklist, we brought in, as I was saying, we brought in an elder, a Chickasaw elder. We have people from the Department of Family Services, which is basically our mental wellness team. And then we also brought in somebody from what we call the Department of Administration. And she works with policies across the whole of the Chickasaw Nation. And then we recently brought in the Department of Health to get the support. So we're kind of like going a little bit, you know, pulling one from here. And so right now we're about 4 departments. So we're growing with the support.
I like your philosophy of working with the willing, right? Like, instead of trying to get a top-down approach where, you know, the leader of the nation tells people that they have to go to this meeting and they have to do this thing, you know, starting with the people who are already interested and already working towards some of the kinds of goals that you're interested in, I think sounds like it's worked well for you.
It has. And I actually think that's what you encouraged me to do 2 years ago. Find people who are interested and find people who are willing, just like you all are. I know that that worked. Thank you.
It's a lot easier to work with people who want to be there, right? Who feel like there's something in it for them. Can you talk about that sort of what's in it for me conversation? How did you get your partners to come to the table, right? Because that's always that sort of Venn diagram between here's what you're doing, here's what I want to do, and here's how we can do that together.
I joined the committee to begin with, and I always just say yes to whatever they say. Will you help us with this, or what, you know, and just be involved. And then I told them about health and all policy and asked if I could do a presentation. So that's the deal. I just, you know, I asked if I could do that, and I think, if I'm trying to remember, Tatiana may know this part, is if I had already met Tatiana. I had already found the tool that I thought would work for us. And I put together a presentation and just asked if I could do that, and to see if I could get support and buy-in. And thankfully I did. So.
You're muted, Sandra.
Yeah, this is not my day for being off of unmute, right? Sorry about that. I don't see other questions in the chat, but I'm going to put Tatiana on the spot. Tatiana, would you like to just give a little bit, add anything to what Judy said about their adaptation of the High-C tool? Or is something that you would like to say about the use of the tool? Because I think it is such a great, succinct way whenever you don't have time to do an HIA or that's not in your organization's culture.
Can you hear me okay now?
Yes, that's better. Thank you.
Okay, thank you. So first of all, I would like to really thank Dr. Parker for innovation and for working with the tool and kind of bringing it to Chickasaw Nation. What I think would be what we have been seeing, that hopefully that structure of the tool, kind of that table format and that checklist, helps individuals that try to innovate and work with this tool to more quickly connect policy with health outcomes. And so, and also they honestly can just use parts of this tool if it works for them. So if they just want to use the checklist part to join the conversation with the city council and say, have we thought about those potential impacts, even if they don't do the full health impact checklist. So we hope that this tool has enough flexibility to allow for that. And most importantly, what Dr. Parker's team did is adapt that to their needs. So if they look into their list, if they're working with their community, if there are some items that would be very important to consider, that allows to expand to those and add to the list. And so one, I think, lessons learned is just go at it and try to experiment with it. So don't maybe spend too much time on just developing the tool or adapting it, but rather than also trying to just use it on a policy, like Dr. Parker said, an existing policy, and see what are the findings and if it's helpful for the discussion.
Thanks, Tatiana. I think it's a really valuable contribution to the field. And thank you, Judy. I do not see other questions, but I'm going to pause for a minute and give folks an opportunity to unmute themselves and either ask a question or express an appreciation to Judy for her time today. Emojis are also good for that if you want to give a clap emoji. And we also have a survey, after action survey in the chat that Emily put together for us.
Thank you for all the virtual claps.
Thank you, Judy.
Thank you, James. I wanted to hear your voice. Thank you all for having me, and have a great and safe 3-day weekend.
Thank you, Judy. And with that, I'm going to sign off and invite people once again to join Sophia for the low price of $22. And our survey for our members is also out.
All
So
right.
thank you.
Thank you.
Thank you so much, Judy.
Thank you.